Okay, when we talk about the stressors of flight, it depends on the book you read. There's anywhere from 7 to 700 stressors of flight. These are the ones that are the most commonly touted. Now, we all know that as we go up in altitude, because of the factors we just talked about, there's going to be decreased oxygen available. So we see a decreased partial pressure of oxygen, obviously, as our very first stressor of flight. As we go up in altitude, barometric pressure decreases, so not only does that decrease the amount of oxygen that's available in any given volume of air, but that also means that things that are swelling are going to swell more. So there's less pressure pushing down on the body tends to swell. Thermal changes are another thing that we deal with. Remember, we already talked about Charles' law. We said that as we go up in altitude, for every 100 meters, our temperature is going to drop by about 1 degree Celsius. Now, when you take the decreased partial pressure of oxygen and you put that on top of a decrease in the temperature, you can see why that can be problematic for patients who are critically ill. We know that when we're hypothermic, the very first thing that we do is we try and warm ourselves up by increasing our metabolism. Well, in order for metabolism to work, you have to have what? Well, you have to have oxygen. Well, if we don't have oxygen and we don't have metabolism, or we don't have oxygen and we have to increase our metabolism, that obviously can create pretty significant problems. Some other things that we deal with, there's a decrease in humidity. The vast majority of the water that's on the planet Earth is closer to sea level. The higher up you go, the less water there is at the altitude. And especially once we get up to really, really high altitudes, we have almost no humidity. And if we're going to be flying at really, really high altitudes, we typically have to do that in a pressurized aircraft. And remember that aircraft, the way that they pressurize air, their very nature decreases the humidity in the cabin. So we want to be very cognizant of that in people who are very fluid dependent. Noise and vibration are two other big stressors of flight. We tend to be very cognizant about those two in the patients it matters the least in. We tend to be really good about addressing noise and vibration in like your conscious alert patient who's having an MI that you're transporting, but we tend to be pretty poor about addressing it in patients who are under chemical paralysis. Remember that under chemical paralysis, we have a responsibility to adequately manage pain and to adequately manage sedation. And remember that pain and sedation are both supply-demand issues. And what I mean by that is the more pain you have, the more analgesic I've got to give you to control it. The more you're stimulated, the more sedation I have to give you to keep you sedated. So when I'm going out to get somebody who's in a hospital in a relatively quiet ICU room, they may be on a Versed drip at say 7 milligrams an hour and they're doing fine. If you take that same patient and put them in an aircraft and shake them for the next 30 minutes and expose them to 100 decibels of noise, 7 milligrams of Versed is not going to cut it. All that is stimulating them and fighting to keep them awake. In addition to that, any injuries that they have are going to be magnified. The pain is going to be magnified by the vibration of the aircraft. So we need to be very, very aggressive with our sedation and our pain medicine in anybody who's under chemical paralysis, or even anybody that we're just trying to keep down with sedation and pain control. Okay, when we talk about fatigue, fatigue is a major contributor to your stressors of flight, and the more tired you are, the less you're going to be able to tolerate flight. And finally, G-forces are the last big stressor of flight that we have to deal with. Remember that your body was pretty much designed to go this way, and that's about it. It certainly wasn't designed to go this way, or this way, or this way, or this way. And so each time we expose the body to unnatural G-forces on a micromuscular level, we have all kinds of contraction occurring to maintain an adequate blood pressure, maintain good blood supply everywhere, and that all demands metabolism, that all demands oxygen. So when you've got somebody who's barely sitting on the teeter-totter where they've got enough oxygen supply to meet the demand of tissues, taking them up to altitude can cause that teeter-totter to sway one way. You may see that all of a sudden oxygen supply can't keep up with oxygen demand. As that oxygen demand increases, oxygen supply is no longer adequate. That's why we typically put everybody that we fly on some level of oxygen depending on how ill they are. Okay, now when we talk about the things that are going to potentiate flight, the little acronym that everybody loves to use is DEATH. DEATH are the 5 things that make all those stressors of flight we just talked about worse. The first one is drugs. And when we talk about drugs, it's not just what you would think of as like being your big heavy gun drugs like fentanyl and things like that. A lot of your over-the-counter medications have profound effects on your ability to tolerate flight. And when I talk about drugs, some classic examples of drugs that can cause really big problems are drugs like Benadryl, NyQuil, prescription drugs like beta blockers and calcium channel blockers. All those things decrease your ability to tolerate an increase in altitude. So we want to be very cognizant of that. There's exhaustion again. The more tired you are, the more the stressors of flight are going to impact you. A person who rolls their car at 7 o'clock in the morning driving to work is going to tolerate their injuries much better than somebody who rolls their car at 4 o'clock in the morning after going to work all day and going to the bar and drinking all night. Speaking of drinking, alcohol is another thing that dramatically increases our inability to tolerate the stressors of flight. The more alcohol you have on board, the harder it is for you to tolerate those stressors of flight. Now, when we talk about tobacco also is another big contributor to decreasing our ability to tolerate altitude. And when we talk about tobacco, the patients where it's probably the most problematic are your smokers. Remember when we talk about smoking that smoking normally causes patients to have an increase in CO that's floating around in their blood. A normal carboxyhemoglobin level for a chronic smoker can be as high as 3 or 4 or 5. And we all remember that CO binds to hemoglobin much higher than oxygen does. So if you're a smoker, that dramatically decreases the amount of oxygenation you have available, period, even more so once we take you up to altitude. Now, when we talk about hypoxia, one of the quickest places where we actually see changes with hypoxia is actually our vision. The cones and rods of our eyes are one of the most sensitive parts of our body to changes in oxygenation. And when we talk about a normal, healthy person, a normal, healthy, well-fit person can typically go from sea level up to about 5,000 feet before they first start to see changes in their night vision. So as we go up in altitude, a normal healthy person has relatively normal night vision until we get to about 5,000 feet. From 5,000 feet and on, they start to see a decrease in their night vision. Well, the big thing to remember about smoking is that people who are chronic smokers effectively reduce their night vision by 4,000 feet. Well, what does that mean? Well, that means that a normal healthy person can go up 5,000 feet before they start to see decreases in their night vision, whereas a smoker, they only have to go up 1,000 feet and they already see changes in their night vision. So smoking definitely increases our stressors of flight. And finally, the last thing that increases the stressors of flight is hypoglycemia. Obviously, you have to have two things for cells to work. You have to have oxygen and you have to have sugar. So if we don't have enough sugar to go around, then cells aren't going to metabolize the way that they're supposed to, and that's going to increase the stress of flight. Okay, when we talk about atmospheric pressure, just a couple of quick words here. Remember, when we're talking about atmospheric pressure, we're talking about the pressure of the atmosphere weighing down on us. And we know that the closer we get to sea level, the more stuff is on top of us, the more molecules of gas are on top of us. Now, when we measure atmospheric pressure, the way that it's measured is we measure it as a 1 square inch column of air that starts at sea level and goes all the way out to space. So that 1 square inch column of air going from sea level all the way out to space weighs something. And on what's called a national standard day or a standard atmospheric day, we would see that would actually weigh about 14.7 pounds. So there's 14.7 pounds worth of air weighing down on you when you're in a standard day, as they call it in aviation. Now, obviously, we can also measure that as a pressure. That's how we actually measure it in aviation, as a pressure. And so 14.7 pounds weighing down on you creates a pressure of about 760 millimeters of mercury, or about 760 torr. So there's a pretty significant pressure weighing down on you. The big thing you need to remember about the principle of atmospheric pressure is the closer you are to sea level, the more little changes in altitude affect the pressure that weighs down on you. When we get closer to sea level, there's more and more stuff weighing down on us. So when we go, say, from sea level to 1,000 feet, that creates a huge change in atmospheric pressure that's bearing down on us. So if you were asked a question that said something like, which flight crew would experience changes in atmospheric pressure more, a flight crew that sits in Denver at 7,000 feet on the pad and goes to 8,000, or a flight program that sits at sea level in Florida and goes to 1,000, you know that the correct answer is actually the program in Florida. The program in Florida, there at sea level, is going to see much more significant changes in altitude at sea level than the program in Denver is, going from 7,000 feet to 8,000 feet. Okay, now when we talk about atmospheric pressure, the other thing we need to do is compare it to water pressure. Remember, when we talk about water pressure, every 33 feet of fresh water, or about every 34 feet of salt water, is going to increase the weight on the body by one whole additional atmosphere. So in other words, when I go down to 33 feet, I've increased the pressure on my body by another 760 millimeters of mercury, or by another 14.7 pounds. When I go down to 66 feet, I increase it by another atmosphere. When I go down to 99 feet, I increase it by another atmosphere, and so on and so forth. So, in diving, a lot of times you'll hear people talk about things in relation to atmospheres, like how far did you go down? I went down 2 atmospheres. Well, how much is 2 atmospheres? Well, that would be 66 feet. Now, one of the questions they may ask you is they may say, okay, you've got a patient who's had a diving emergency and they were exposed to water at 66 feet. How many atmospheres of pressure were on that patient? Instinctively, you want to say 2. 33 feet plus 33 feet, that would be 2 atmospheres. But remember that you've still got the atmosphere above the water. Now, just to make things even more complicated, we've also gotten feedback that people have said things like on their exam, they asked how many atmospheres of water pressure were you exposed to. Well, if they're just asking you atmospheres of water pressure, then in that same scenario of 66 feet, we know that the answer would be 2 atmospheres. So if you see a question like that, read it really closely. Are they asking me how many atmospheres of water pressure, or are they just asking me how many atmospheres? Because if they're just asking me how many atmospheres, I also need to account for the atmosphere that's above the water. Okay, now when we talk about altitude zones, there's 4 different altitude zones that you need to know about. The first altitude zone that you need to know about is the physiologic zone, and this is basically where people were designed to work. The physiologic zone goes from sea level to 10,000 feet. And again, that's the altitude people were typically designed to live at and to be able to tolerate well, assuming they're in generally good health. Once we go above 10,000 feet, from 10,000 feet to 50,000 feet, we enter what's called the physiologically deficient zone. Now, the higher up we go, the more deficient the zone becomes. And so above 10,000 feet, we start to need extra stuff in order to be able to survive. If we're going to say 15 or 20,000 feet, we're going to need supplemental oxygen. Once we get up to really high levels, like once we start getting up around like 30,000 feet, 40,000 feet, 50,000 feet, we would have to have much more than just supplemental oxygen. We would actually have to be in a pressurized environment to be able to tolerate that altitude safely. Once we get above 50,000 feet, we enter what's called the space equivalent zone, and the space equivalent zone goes all the way from 50,000 feet to 250,000 feet. And in this zone, there's no way for us to survive, not even for a minute, unless we have some artificial environment that we're in, like some kind of pressurized aircraft or some kind of pressurized suit. Between 50,000 and 250,000 feet, a number that you need to know is 65,000 feet. 65,000 feet is what's called Armstrong's line. As we're going up in altitude, as we pass through 65,000 feet, we pass through Armstrong's line. And the big thing that's important about Armstrong's line is that is the point in transition where the barometric pressure in the atmosphere becomes less than the barometric pressure in the body. And so the thing that's significant at that point and beyond is not only can you not on-gas, any gas that you had in your body is going to go down the concentration gradient. So any gas you had in your body is actually going to leave. It's going to escape into the atmosphere where it's lower pressure. Finally, above 250,000 feet is space, and we all know that in order to be able to tolerate space, you would have to be in an artificial environment. Okay, when we talk about hypoxia, there's 4 big types of hypoxia that you need to know about. Hypoxic hypoxia is the one that we focus on, the one that we know the best, and the one that's been around for the longest. It's the one that we focus on in all of our basic nursing and basic EMS training. When we talk about hypoxic hypoxia, this is the patient who is hypoxic because they can't get oxygen into their body. So a good example would be like a patient who's apneic because of a narcotic overdose. Or if I was to hold a plastic bag over my head, I would get hypoxic hypoxia. So again, the big thing with hypoxic hypoxia is the patient cannot get oxygen into their body. Now, when we talk about the other types of hypoxia, the next big one that you need to know about is you need to know about hypemic hypoxia. Hypemic hypoxia is where we have the ability to get oxygen into our body, but we don't have any place to put it. And we know the place that we put it is in blood, specifically on red blood cells. 98% of the oxygen in your body, in your blood, is bound to hemoglobin. So what would cause a patient to be hypemic hypoxia? The absence of hemoglobin. So the way I always remember hypemic hypoxia is I always remember hypemic anemic, because people with hypemic hypoxia are going to be people that are anemic. So it's a decrease in oxygen carrying capacity. The big thing you need to know about hypemic hypoxia is it's actually one of the strongest, most powerful types of hypoxia in the body. Because 98% of your oxygen is bound to your hemoglobin. If we cut your hemoglobin in half, we've essentially cut your oxygen in half. So hypemic hypoxia is a profound cause of hypoxemia. And we always want to be looking for that. We always want to be assessing our patients, not only to make sure they have hypoxic hypoxia, but also to make sure they don't have hypemic hypoxia. Okay, when we talk about stagnant hypoxia is where the patient has the ability to get oxygen in their body. They've got plenty of hemoglobin to carry the oxygen, but the hemoglobin's not going anywhere. And so I compare this to a train station. Imagine a train station where there's lots of people in the station, i.e. lots of oxygen molecules. There's lots of train cars, i.e. there's lots of hemoglobin to hold the oxygen, or train cars to hold the people. But the cars are broken. They're not going anywhere. They're just sitting in the station. That's exactly what's happening in stagnant hypoxia. You have good oxygen availability, you have good oxygen saturation of the hemoglobin, but the hemoglobin aren't going round and round like they need to, so therefore cells and tissue are not getting the oxygen they need. Now when we talk about stagnant hypoxia, we can have that on a local level or we can have that on a global level. A good example on a local level would be like a compartment syndrome. If I've got a compartment syndrome and this tissue's all swelling, then it's going to be really hard for me to push blood in there. More importantly, it's going to be hard for me to get blood out. Once the compartment syndrome exceeds my venous pressure, then venous blood is no longer going to exit. It's just going to be stuck there. Well, as that starts to increase the amount of pressure in my arm, there'll be a point where the pressure increases to the point where arterial pressure is less than pressure in the arm. And then not only have we lost the outflow of blood, we've lost the inflow of blood. So all that tissue in that compartment syndrome extremity has stagnant hypoxia. We can also have stagnant hypoxia, though, on a global level. And a great example, probably the best example, is like cardiogenic shock. When people are in cardiogenic shock, their heart is not effectively contracting, and so blood is not moving round and around like it's supposed to. Finally, histotoxic hypoxia is the last type of hypoxia, and histotoxic hypoxia is characterized by the patient who has the ability to get oxygen into their body, has plenty of hemoglobin to carry it, has plenty of cardiac output to make it go round and round, but for whatever reason, the oxygen either can't enter the cells, or when it enters the cells don't use it. And so histotoxic hypoxia is almost always caused by toxicologic emergencies. So I just remember histotoxic, toxic. And when I talk about histotoxic hypoxia, some great examples would be things like cyanide poisoning, alcohol poisoning, CO poisoning, all those different types of things. Now, we've talked about the 4 types of hypoxia. One thing I do want to point out here is the way that we assess hypoxia. When you ask your average clinician, how do you assess to see whether or not somebody's hypoxic, what most people would say is, I look at the pulse ox. Well, when we look at the pulse ox, when you look at these 4 types of hypoxia, how many of them can you rule out with a good pulse ox? The answer is 1. The only type of hypoxia that we can rule out with a pulse ox is hypoxic hypoxia. If I've got a patient who's got hypemic hypoxia because of the fact that half their blood volume is gone, is that going to change my pulse ox? No, because when those hemoglobin molecules pass my pulse ox, they're going to show that they're 100% saturated. Even if there's only 1 hemoglobin molecule left in the entire body, every time it passed the pulse ox, it would show 100%. Same thing with histotoxic hypoxia. If I can't use oxygen, how is that going to represent itself on my pulse ox? Well, it's not going to represent itself as hypoxia because there's plenty of oxygen on the hemoglobin. And we can even say the same thing with stagnant hypoxia. Assuming that there's enough circulation to at least get blood to pass by the pulse ox sensor, if it's stagnant hypoxia, that doesn't show up on our pulse ox. So when your pulse ox is normal, all you have proven is that the patient doesn't have hypoxic hypoxia. We need to independently assess for all these other types of hypoxia. And in our acid-base series, we spend lots of time talking about how to do that. Okay, now when we talk about decreased partial pressure of oxygen, remember that there's 4 stages to hypoxia. The first stage is what's called the indifferent stage. In the indifferent stage, the patient or the person who's hypoxic has a complete and total ability to compensate for their hypoxia. We see that the heart rate increases, the respiratory rate increases, and the only real deficit we see, if you will, is we may see a slight decrease in our night vision. Now, The indifferent stage of hypoxia is the most important stage of hypoxia because it is the only stage of hypoxia where you will still have a normal level of consciousness, still have all your faculties about you, and still have all your critical thinking skills. As we move into the next stage of hypoxia, we call that the compensatory stage. In the compensatory stage, what we see is an increase in blood pressure, but more important, this is where task performance goes out the window. This is where we lose our critical thinking skills. And I said the indifferent stage was so important because once you get to the compensatory stage, you won't recognize the fact that you're hypoxic. If you talk to people that have been exposed to lots of hypoxia, they'll tell you that of all the ways to die, it's not a bad way to go. One of the classic groups of people that experience this a lot are Navy SEALs. When Navy SEALs are going through their vigorous training, one of the things that they do is they do a lot of drown-proofing exercises with them where they learn to survive hypoxic in the water. And basically what happens is they hold them underwater until they become profoundly hypoxic. And those guys will tell you that of all the ways to go, drowning is the way to go because as you become hypoxic, as you go through that indifferent stage, you go through what's called the guppy stage where you're like, oh my God, I can't breathe. Oh my God, I can't breathe. But when you move from the indifferent stage to the compensatory stage, you lose your critical thinking skills. And all of a sudden your thought process goes from, oh my God, I can't breathe, oh my God, I can't breathe, to, hey, I'm feeling kind of funny, the pool's kind of blue. All of a sudden you don't care about the fact that you're dying of hypoxia. Basically you get stoned, you get narcosis. Okay, as we move into the third stage of hypoxia, that's the disturbance phase. And in the disturbance phase, what we see is the patient gets dizzy, they start to get sleepy, they get tunnel vision, and for the first time they may actually get cyanotic. And finally, as we move into the last stage is the critical stage. The critical stage is marked by mental confusion and incapacitation, and the critical stage will end in death if there's not some kind of outward intervention to reoxygenate the patient. Okay, now when we talk about changes in altitude related to oxygen, remember that your PaO2 will typically drop about 5 millimeters of mercury for every 1,000 feet that you climb in altitude. So if you're going up, say, 4,000 feet, we would expect that somebody's PaO2 is going to drop by about 20. So it's a pretty significant drop. Now, one of the questions that they may ask you about on the test is they may ask you what you need to do to calculate if you have a patient who's on a very prescribed amount of oxygen and needs to stay on that same amount of oxygen, that same oxygen delivery at a different altitude. And really, for the most part nowadays, this formula is really archaic and we don't use it that much anymore. But there is one probably good exception. If you were transporting a neonatal patient or a pediatric patient who had cyanotic heart disease and had a ductal dependent lesion, one of the things that we need to do to keep the ductus open is we need to keep their oxygen level at a very specific point. So in that patient, we may need to be very careful about how we oxygenate them at a given altitude. So the formula is actually pretty simple, and if you see a question like this on the exam, they're going to give you all the variables. They just want to know that you know how to manipulate the variables to come up with the answer. So to come up with the answer, in order to keep the same level of oxygenation at a different altitude, we're going to use the barometric pressure and the FiO2. Remember, FiO2 is the percentage of oxygen that the patient's inhaling, so we would take the FiO2 and we would multiply that times the barometric pressure that the patient is at right now, i.e. when we go in to pick them up. What we're going to do is we're going to take the FiO2 and we're going to multiply it times that barometric pressure that they're at right now. Then we're going to divide it by the barometric pressure that they're going to. So for instance, let's say you got somebody who's on 50%, they're at 760 millimeters of mercury, but the altitude that you're going to take them to is only 730 millimeters of mercury. So you would take 50% times 760 divided by 730, and that would give you the new percentage of oxygen that they're going to need to be at the new altitude. Okay, last but not least, we need to talk about effective performance time and time of useful consciousness. These are two terms that a lot of people use interchangeably, but they're actually two very, very different things. First, let's talk about effective performance time. Effective performance time is how long can somebody do their job in an inadequately oxygenated environment. The way that they do this, the way that they measure this, is in the military they take volunteers and they put them into a compression chamber. And they give them tasks to do that are part of their normal job tasks. And they figure out how long can the person do that with the same consistency and reliability and timing and everything as they did it at a normally oxygenated environment. So for instance, they may take somebody at sea level and get them to do a drill and figure out how long does it take them to do that drill and how many errors do they have, and then have them do it over and over again so they get an average. And then take that same person and put them in the compression chamber and take them up to an altitude of 15,000 feet. And then at 15,000 feet, they do the same thing. They have them do the drill over and over again, and they say, how long now at 15,000 feet can the person do it and still maintain the same time and the same number of errors? Once the time increases or the errors increase, we know that we've reached our effective performance time, and we may know that at 15,000 feet, that's, 10 minutes or something like that. So that's what effective performance time is about. What we're more concerned with is time of useful consciousness. Time of useful consciousness is how long can somebody protect themselves in an inadequately oxygenated environment. So basically the way that they do this is they take those same volunteers and they put them in a compression chamber, and they may say throw a Nerf ball at their head over and over again. And they figure out how long can this person maintain enough of a level of consciousness to know that when the ball's coming at my head, I need to either move my head or move the ball out of the way, or I need to do something so I don't get hit in the face. That's what time of useful consciousness is about. That's the one that's really important to us in air medical transport. It's how long can you protect yourself in an inadequately oxygenated environment. Now, obviously, the higher up we go in altitude, the shorter our time of useful consciousness becomes. And when we look here at this chart, you see that when people are between 12 and 20,000 feet, time of useful consciousness is actually pretty substantial. You've got like 20 to 30 minutes before you're going to be unable to protect yourself. And obviously, the higher up we go, the smaller that number is going to be. So at 12,000 feet, you may have 30 minutes. At 20,000 feet, you may have 20 minutes. Now, once we start getting into really high altitudes, like say 40,000 feet, you see at 40,000 feet, you've only got 15 to 20 seconds to protect yourself. Once you're above 50,000 feet, it slows to, or it shortens to as little as 9 to 12 seconds. Now, the one thing I do want to say about time of useful consciousness is when you look at these standard charts, there's two things you always have to keep in mind. The first thing is that these charts were based on military personnel, which are relatively healthy, a lot of which are younger and healthier than most of us probably are. The second thing I want to say about time of useful consciousness is remember that anytime we're talking about time of useful consciousness in the setting of an explosive decompression in an aircraft, so for instance, like we lose a door, we lose a seal, and the aircraft has an explosive decompression, whatever the time on the chart is cut in half. So for instance, at 40,000 feet, you've got 15 to 20 seconds, but if at 40,000 feet you were exposed to that altitude because of an explosive decompression in your aircraft, you don't have 15 to 20 seconds, you have 7.5 to 10 seconds. So you have a really short period of time. So obviously that's why when you're riding on an airliner, they always say in the event of a sudden cabin depressurization, oxygen mask will fall from the ceiling, and you're supposed to do what? You're supposed to put it on you first, because if you spend 15 seconds wrestling with somebody else, or if it's an explosive decompression, you spend 7 to 10 seconds wrestling with somebody else, then you're just going to become obtunded, they're going to become obtunded, now nobody's awake. So we always put oxygen on ourselves first. All right, well, that is our discussion of flight physiology. If you have any questions, feel free to email us. My personal email address is abaca@camanagement.org. That's abaca@camanagement.org. Thank you for spending your time with us, and we really appreciate you.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to.